So first speaker for the afternoon is Josh Yamada. You've heard some wonderful stories about how he's helped people, so he will tell us a little bit about how he does it, the nuts and bolts of it. He's really, I think, changed the field in many ways in introducing radiosurgery to the treatment of chordomas, and I'm sure he'll talk about that along with other radiation options that are available.
Thanks, Ilya. I just want to make sure that everybody knows I'm the other Josh. But not the Josh. It's truly an honor and privilege to be associated with you. You know, there's a old Chinese saying about how to get to know someone, and it goes something like, don't tell me what you've done, but tell me where you've been. And I really feel like chordoma is one of those diseases where it's truly a journey. And I think that really applies to all of us here. As we learn from each other and talk about our journey. And I hope that as I talk to you a little bit about updates about radiation therapy and chordomas, that you'll get a sense too that it's been a bit of a journey. And I think we're really at the cusp of some very, very exciting ideas incorporating many of the things you heard this morning and how radiation therapy can fit into all these exciting advances. So first update I'm going to give you is Tom Delaney's, I think, very important paper that he published last year on their experience of phase 2 trial, so a prospective study where the majority of the patients were chordoma patients, and these patients underwent preoperative radiation followed by resection and then postoperative radiation. In this series, biopsy was allowed for unresectable tumors, so they did have a number of patients who received no surgery, just basically a biopsy, and then the radiation was the predominant treatment. This is an update on the experience that Dr. Bilski showed us this morning. So now for this group of patients, the follow-up is now exceeding 7 years as the median follow-up. So this is their updated experience. In terms of the radiation treatment, I'm not going to bore you with all the details except to say that the majority of patients received about 5 weeks of radiation, it's proton beam radiation, preoperatively, underwent surgical resection, and then had about a little over 2 weeks of radiation postoperatively to the post-surgical tumor bed. If it was microscopic disease, that's all they got. If there's actually gross disease, which actually means that the surgeons were not able to take out all the tumor, and there's actually disease that they knew the tumor they could either visualize on a scan or actually palpate or feel during the time of surgery, those patients got actually a slightly higher dose of radiation postoperatively. Some of the patients also got intraoperative dural brachytherapy as well. So those are for the spinal tumors. In this series, which they've updated, 23 primary chordomas and 6 recurrent chordomas. It's interesting to note that, of course, how patients are treated up front really there's a huge difference in outcomes. 22 out of 23 primary chordomas, in other words, that was their first treatment, were locally controlled, as opposed to only 3 out of 6 for those that were recurrences. So here's the breakdown on outcome. Local recurrence means that the tumor has come back in the original site, and only 1 out of 26 of those who had this type of treatment as their primary treatment, in other words, diagnosed, then went on to have the MGH paradigm, only 1 out of 26 of those patients recurred. And then they also broke out their experience by the degree of successful surgery. And R0 resection means that they were able to get the entire tumor out. And of course, those patients did the very best, 100% local control. On R1 resection means that they got the gross tumor out, but they left behind microscopic amounts of chordoma cells. Microscopic meaning the surgeon was able to visualize any tumor left behind. It would only be a small amount of cells. You would need a microscope to be able to see it. So if it was a microscopic residual, then they still got very good results, 1 out of 10 recurrences. If it was an R2 resection, fortunately, there weren't many of those. That means they actually were not able to remove the entire tumor. And so despite their best efforts of high-dose radiation, 1/3 of those patients ended up having local recurrence. Of the patients that had biopsy only, so the tumor was too extensive for surgery, then I think this is actually a pretty amazing outcome. Only 2 out of 9 recurred. So it almost would seem like a biopsy might be better than an R2 resection in terms of outcomes. So that does suggest that radiation therapy, if just the biopsy, can still provide patients with a high degree of probability of controlling the tumor. And so this, I think, is in one sense very provocative, because there may be some cases where it's better not to do the surgery if it's going to be an R2 resection. Well, of course, these are small numbers, but still something to think about. This is a prospective study, and so I think the data here is very good. So what are their conclusions? Okay, first of all, high-dose radiation is very feasible. They use proton beam radiation. The morbidity, which means the complications of treatment, is very acceptable. They had no incidences of spinal cord damage, even though they actually take their spinal cord doses to much higher doses than we traditionally do with photon radiation. It has nothing to do with the type of radiation. In other words, proton radiation is not safer on the spinal cord than regular X-ray radiation. It's just that the physicians are more comfortable taking the spinal cord to higher doses when they use protons. And so that's, now that I've started treating patients with protons, I found that's one of their dirty little secrets about proton beam radiation. They can just take normal structures to higher doses and feel okay about it. There's no biology behind that. They found that nerve damage, sacral nerve damage, is uncommon, and doses less than 70 gray, which is about 7 weeks of radiation, they actually found no incidence of nerve damage. So some very interesting data and important data, because this is not retrospective data that was collected after the fact. This was a prospective phase 2 study. Now, they also say, and I think this is also important to keep in mind, that recurrences are very difficult to recover from. And I think that's an important point we should keep in mind, because in many areas outside of the sacrum, an R0 resection is pretty much, well, I wouldn't say impossible, but very uncommon to be able to achieve that, either in the spine or in the skull base. So, but still, I think, this is very good data to keep in mind. I'm just going to take a second and give you an update on our experience, because we have a very different approach to radiotherapy. The traditional approach for radiation for chordomas is to give a small amount of radiation over extended periods of time. So this is like 7-8 weeks of radiation at small doses per fraction has been the conventional way to treat chordomas. Our approach here, based upon extensive data of treating very radioresistant spine tumors, mainly metastatic ones, is to use radiosurgery. That's a high dose of radiation in a single fraction. You might think of the difference, this may date me a little bit, but do you remember the days when we used to drink orange juice out of concentrate? We don't do that anymore. I guess that's a sign of progress. But it used to be my job to pull the orange juice out of the freezer and mix in 3 cans of cold water. And I noted right away that if it wasn't exactly the right amount of water, the juice just didn't taste quite right. Not quite enough, and it was a little sour, too much, and it was a little too dilute. Well, radiation is sort of like that. The more water you add to the concentrate, the more dilute its effect on tumor cells becomes. Normal tissues can tolerate diluted radiation to a high dose. And so that's why we can give long courses of radiation where the cumulative dose of radiation is quite high. However, that also means that the tumors get kind of a diluted treatment. You overcome that by just doing it multiple times. Radiosurgery is the exact opposite paradigm. It's drinking the orange juice with forgetting to add the water, essentially. What that means, though, however, is it's very potent in terms of where you aim the radiation. Radiosurgery is safe if you make sure that the radiation just treats the tumor, but gives low-dose radiation to everything else. And so, since chordomas do not respond traditionally very well to conventional fractionation, our approach has been to use radiosurgery, something that we've developed a fair amount of comfort and expertise in doing. So I'm just going to give you our update, because we published our initial series about, 2013. And so we published on 24 patients. I'm going to give you our outcome on 31 patients. This is unpublished data. In fact, it's fresh out of the computer from last week. So we have, at single fraction radiosurgery, you have 2 recurrences with follow-up out now past 9 years. The median follow-up for this group is now 40 months. One of our 2 failures happened at the 18 gray level, which we already know is an inadequate dose of radiation. So if you look at all the patients who had the full dose of 2400 centigray, which is the same thing as 24 gray, all in a single session, we've had 1 failure in that dose group. Here's the actuarial outcomes. This is local control at our highest dose level, 24 gray in a single fraction, and that's running at about the same as we published before, a little better than 90% of our patients are going without local failure in a single fraction. So this is a completely different paradigm than multi-fraction, long-course radiation. So there may be some interesting things to think about from our experience of radiosurgery. One of them is that radiosurgery provides equally excellent local control. I will tell you that the majority of our patients never underwent surgery. In fact, our intention for sacral tumors, which we've been doing with Dr. Boland, is to give radiosurgery prior to the operation. But a number of our patients actually feel so much better, and they're concerned about the morbidity of a sacrectomy, that they actually have refused the operation. Honestly, I would prefer that the patients went ahead and had the surgery so I can have the pathology to prove what radiation is able to do without waiting 10 or 15 years. But that's a selfish thing. But our patients are feeling well enough. They've actually, a number of those patients have refused surgery. About half of them, I think, have refused the operation after radiosurgery, and you can't blame them at all. In fact, we had a meeting on sacral tumors a couple of years ago, and the majority of the sacrectomy surgeons themselves would have reservations about undergoing a sacrectomy. So I think we can totally understand why the patients would have reservations about the surgery, especially when radiosurgery appears to be shrinking their tumors and controlling their symptoms very well. So it does provide good local control. We have about a 5 to 6% neuropathy rate, that means nerve damage rate, in this patient cohort, mainly in the sacrum. And foot drop is a common complication of radiosurgery in the sacrum. Sacral fractures are also a potential problem, and these are very difficult to effectively palliate. But I do want to just consider for a second salvage of recurrent disease. Radiosurgery with using varifocal radiation, this may be a very important niche, so to speak, for varifocal radiation treatment, is what to do if the tumor comes back. And a number of our patients in our database have been successfully salvaged. And so, we're thinking that this may be an important part of our armamentarium in helping patients who have had recurrence of their original tumors. And this we can do even in the setting of prior radiation therapy. Dr. Bilski talked a little bit about intraoperative radiation. This is something that's still relatively unique to here. There are a number of institutions that have sent training teams to MSK to learn how to do this. It's a very simple concept. We believe the dose of radiation makes the difference between successful treatment and not successful treatment. Around the spine, one of the biggest weaknesses is the radiation dose of the spinal cord. If we give radiation treatment during the operation, we can essentially give radiosurgical doses of radiation to the dura, that's the lining around the spinal cord, whereas the spinal cord itself receives less than 5% of the surface dose. That's almost free radiation, and this is very important, particularly in patients who've been previously irradiated. This is a very good way to manage this problem. And this is a graph that shows what happens to the radiation dose with distance. And this is millimeters, okay? This is not centimeters or inches. This is millimeters. So you can see what happens to the radiation dose when you get even a couple of millimeters away from the radioactive source. The radiation dose goes to less than 5% in really a space of 3 millimeters. And we're able to deliver enough radiation that probably would kill a chordoma cell pretty well, 24 to 25 gray, which is our radiosurgical dose. We can do it usually within about 10 minutes in the operating room and provide very effective sterilization of an area that's otherwise very difficult to treat. So here we've treated probably at least 150 cases like this. Some of them have been chordomas, particularly patients who have had prior radiation. This has become very handy. So we published a couple of papers on this, and this is just these squiggly lines, represent a radiation dose map. I know it looks like, it's from some advertisement about how to make your spine look better, but all it is a radiation dose map. And so these lines represent levels of energy of radiation, just the same way that a contour map would show at different altitudes. And so the higher radiation doses are centered around the tumor here, but you can see around the spinal cord, we're able to minimize the radiation dose. That's the spinal cord, there's that disc right there. This yellow thing represents where we put the radioactive plaque. If we do this, then we have to treat just a U-shape target instead of treating a donut shape, which is much more difficult to do around the spinal cord. This gives us a bit of an outlet, so to speak, makes it much easier to give a higher dose of radiation to what's left. And so, statistically improved outcomes in terms of how well we're able to cover these difficult targets by the addition of intraoperative radiation. This is a published report on our sarcoma series, which includes chordomas. And this is the outcomes in patients who did not have P32 and patients who did. And these, you have to remember, are probably the more aggressive tumors. They actually have a less rate of local failure than the patients who didn't get it because we felt they probably didn't need it. So this is very interesting data suggesting that it does make a difference, even though we're treating a very small part of the patient, but the most important and vulnerable area, which is around the spinal cord. I'm going to switch gears a little bit and talk about what everybody is really interested in, is the immune aspect of radiation therapy. You've heard a lot about it. And so very quickly, I know I'm running out of time, but this is an interesting experiment that was done here in which a mouse was implanted with a tumor. It was not a chordoma, it was a cancerous growth. And then what they did is they ablated it, which means they caused significant cell death. I think in this case they did cryotherapy, so they froze the tumor. And what's interesting is that these mice were placed on a CTLA-4 blocking agent, which essentially kind of stops the immune cells from dying, and so it kind of helps keep them around a lot longer, so they're available to have immune effects. Since it's an immune modulator, kind of stimulates the immune system. So when they gave these mice an anti-CTLA-4 drug like ipilimumab, and then implanted the tumor, and then ablated it, what they found was not only did they get a nice effect locally, but when they tried to re-implant the mouse with the original tumor, it was rejected. The same way that if you were to take a kidney and tried it, from a non-matched donor and implanted it, and the kidney would get rejected by the immune system, that's what happened to the tumor in the mice, suggesting that if you ablate the tumor with an immune modulator, something to kind of rev up the immune system, that the immune system will be vaccinated against the tumor, in a sense, and reject it. So this kind of stuff is very, very exciting for us. And we would say that radiosurgery is also an ablative therapy. The reason why we say that is that we have biopsy data to suggest that after high-dose radiation, there's really just fibrosis. There's really nothing left. And these high doses of radiation are equally ablative as freezing the tumor. So what does that mean? Well, this is, I think, resulted in a new paradigm for incorporating immune effects into high-dose radiation. So here, if you can imagine a tumor cell gets irradiated, and as that tumor cell dies, it throws off tumor fragments, and these fragments are picked up by cells in the immune system called antigen-presenting cells. They will take those cells, those tumor pieces, and then present them to other elements of the immune system as an antigen, which means that it will now see parts of that tumor as a foreign invader, the same way the immune system would see an organ that's not matched as an invader, or bacteria or viruses, that the immune system will then go ahead and fight. And so it's possible that in the setting where you have an enhanced immune system, and you give an ablative therapy that causes necrosis or death inside of the tumor, this, for example, if let's say this were a chordoma, that it may be very reasonable to think that you have now created an internal vaccine against chordoma cells, and that this kind of idea is behind this trial, which I think is going to be a very interesting trial by Chris Heery at the NCI. Josh talked about it a little bit, so I'm not going to go into detail. But the idea is to stimulate the immune system against brachyury, and we've noted that in cases of high-dose radiation that we have seen responses in these patients. And so this is now going to a phase 2 study, as you heard, just recently opened. And it's based on the outcomes of the phase 1 study, where they had 1 partial response and 1 mixed response, and 6 out of 9 patients with stable disease. So there may be something to this story. We don't really have a good way to control how to expose the brachyury after radiation, and that's, I think, going to be a problem. But I think this is a very important study, and we should really support this study. And if you're interested, here's the information off the NCI website on how to get information about this phase 2 study. And you can find this on the internet in the NCI database. But I think that not just in oncology in general, where these checkpoint inhibitors, which are the immune modulating drugs, are making a big splash in melanoma and renal cell carcinoma, but also, why not in a chordoma? And so Josh was just telling me there's been, 4 proposals for checkpoint inhibitors, which I think is very exciting. And I certainly share that enthusiasm. I would suggest that high-dose radiation is probably going to be an important part of that whole paradigm of creating internal vaccinations, in a sense, to use our own immune systems against the chordoma. I mean, I can't think of a more elegant idea than something like that. So I guess my message to you is that the future in terms of radiation therapy in chordoma is still very exciting. We're moving beyond traditional 2 gray per fraction, 7 to 8 week courses of radiation. There are other paradigms out there. I didn't have time to get into all the differences between high-dose radiation given in 1 to 3 treatments as opposed to doing it in 37 or 38 treatments. But in my mind, the differences in how the tumors respond to high-dose radiation versus conventional radiation, the biology is completely different, and this is a new and exciting era for all of us. Thanks for your attention.